I'm Keiko Greenberg. I'm one of the nephrologists. Well, obviously, I'm going to be talking to you about AKI today. And I'm also the APD for our fellowship program. So I'm actually new at this. But if anyone listening is interested in nephrology potentially as a career, I'd love to meet you. So okay. So I was sitting in the room earlier, wondering if anyone was gonna show up. I know, nephrology isn't always, the most interesting or most, enjoyable topic for residents. But I'm glad you all have joined me. So I want to start with, talking about why acute kidney injury is important. Why should we care about? And then go to what is it, because it's actually sometimes not, not clear cut, as I hope I can convey. And then of course, what causes the AKI, and then the evaluation and management, because you guys are, have already, even as interns, I'm sure you have dealt with it, numerous times already. So what's its significance? Why do we care, or why should anybody care, right? So you guys know that it's very common. So it affects up to 5 to 15%. I've even seen numbers as high as 20% of hospitalized patients, and up to 60% of ICU patients. And of course, it's associated with increased morbidity and mortality. You guys are aware when you're in the ICU, lots of patients who are very sick, who are on CVVH, and unfortunately, most of those don't make it. So you can see. So this is a table from a review where they looked at several studies, studying AKI and outcomes, and pooled all the results together. And you can see that on the very far right bar, among the patients that required dialysis for AKI, the mortality rate was 50%, which is not surprising, necessarily, given how sick the patients are. But I think what I want to point out, that even the patients who have more considered mild AKI, so stage 1, I'll show you the definition of the stages on the next slide. But even the folks with milder AKI that don't require dialysis are still at a higher risk of mortality. So I think in the same paper, they said that folks who have stage 1 AKI are at 3 to 4 times higher risk of mortality than those who don't develop any AKI. And then, among the people that that make it out of the hospital, that survive their AKI, and whatever else is going on during their hospital stay, they remain at an increased risk of developing hypertension and progressive CKD. Okay, so what is it? So typically, you guys don't have to know these definitions, but just to show as a reference. So we look at both, you can look at creatinine definition, or you can look at the urine output definition. I think typically we're, most of us are looking at the creatinine definition, but sometimes there are cases where urine output may be more helpful. So AKI stage 1, urine output less than 0.5 mils per kg per hour for 6 to 12 hours. So that would be the minimum. So anything lower than that would, of course, be considered AKI. In terms of creatinine criteria, so serum creatinine to 1.5 to 1.9 times baseline over a week, or 0.3 milligrams per deciliter or higher absolute increase over 48 hours. So again, you don't really need to know the stages and the definitions. It's more for for research. But so I think the lay definition, or what we all think of as kidney disease, would be defined as an abrupt decline in kidney function characterized by accumulation of creatinine, urea, and other unmeasured waste products. Okay, so which of these patients is AKI? So first you have a 55-year-old woman undergoes a wound debridement on 7/22. So I think our graph starts here late on 7/22, and then develops post-op hypotension. So I think I don't think any of us are going to miss this kind of situation where you're already starting with a creatinine above normal, meaning that when you look in MedConnect and you're looking at the labs, the creatinine, whatever the number is, it's red, right? So and then they have clearly this person has unfortunately developed progressive rise in creatinine and ultimately required dialysis. But if you can imagine, so if you sort of don't look at the y-axis, but imagine that the normal low and the normal high, imagine that you move this blue line down, and imagine if the person started with a normal with creatinine in the quote unquote normal range, and then they developed an increase progressive increase in over the next few days. If the creatinine stays below the upper limit of normal, the numbers are still going to be black. You may not may not notice that the creatinine's rising until it's clearly in the red, and it's clearly above the normal range. Maybe you guys are sharp, but I definitely have had remember situations during residency where looking the patient's creatinine is 2, and looking back the prior 2 days it had gone from 0.8 to 1.2 that I had in the setting of getting vancomycin that I had missed. Okay, so the next patient, you have a 77-year-old man with a urinary tract infection. This is a patient I saw in clinic, and he got treated with Bactrim. So his urologist recommended, a month-long course of Bactrim, of course, and then I saw him. I said, well, let's get some labs. A month on Bactrim seems like a long time. So you can see the baseline labs here. He's an older man, so I wouldn't, I'm not too surprised. I didn't give you his comorbidities, but given his age, I wouldn't expect a normal GFR just from age alone. And then he has some other comorbidities. So his baseline creatinine is 1.2, and electrolytes look normal. So after 2 weeks on Bactrim and he gets labs, creatinine is now 1.6 and potassium is 4.6. So what's going on here? Is this, he's been on Bactrim for a couple of weeks, maybe he's been exposed to it before. Does he have, AIN, allergic interstitial nephritis? Is that why the creatinine is 1.6 and the potassium's higher? But I think if you look at the BUN, you'll notice that the BUN has not changed at all. So if this guy had AIN, I would expect, the creatinine to have, have gone up a little bit. And so the fact, here, in this case, the fact that the BUN hasn't changed is a clue that actually what's happening is that, that Bactrim is increasing it's causing an increase in serum creatinine because it's inhibiting creatinine secretion in the proximal tubule. So I think the clue, after, so we got these labs and I said, he was almost done with Bactrim. So then I made him get labs, after he completed his course, and his creatinine was back down to 1.1. And so, I think it was pretty clear that, this was the effect of trimethoprim. And then, so other drugs, so this is just, a list that off the top of my head while I was making this presentation. So cimetidine also, there are a number of different, transporters that these drugs can inhibit, but cimetidine does this, imatinib does this, and dolutegravir, cobicistat. I only know these because, I was reminded because I saw a patient with HIV that I saw for, for elevated creatinine, and he was on dolutegravir. So that it was a reminder that, to keep that in mind. And of course, why is the potassium higher? Bactrim blocks ENaC, or trimethoprim blocks ENaC, and it reduces potassium excretion. So this guy did not have AKI. All right, so the next patient, a 42-year-old woman who has undergone debridement of a lower extremity wound. And so, so I think her surgery was probably, June, a couple days prior to these labs, but June 15th is a starting point, creatinine 6.4. So clearly, this is a woman who has, advanced CKD. And so the next day, the creatinine's gone from 6.4 to 7.1, the BUN from 61 to 73. And the next day, the creatinine is now 7.38, BUN 77. So the creatinine in 2 days, the creatinine has gone from 6.4 to 7.38. And so, of course, this is a patient I saw as an inpatient. And so every day, the labs look bad. Does she need dialysis? But if you look at the GFR, so she happened to be African American, but you see that her GFR, despite the creatinine going from 6.4 to 7.4, essentially, her GFR actually dropped only, went from 9 to 7. So, technically she meets criteria for AKI because, her creatinine has gone up, by a lot. But it actually doesn't represent a significant drop in her GFR. So, I made a note of it, but, it wasn't really concerning to me. And then over the course of after the 17th, it's sort of her creatinine leveled off at in the low 7 range. So she was stable. So maybe her creatinine, her kidney function dropped a little bit, but not not to a concerning level. And plus there wasn't much I think for us that we could find to to manage her better. Okay, and then you have a patient, a 71-year-old man. So he's followed in our clinic for CKD. He has known members nephropathy. And so his baseline creatinine is around 3.3, which is what you see from August 17th. And he comes in, so he's found to have a renal mass, and he's followed by urology, and they recommend a partial nephrectomy. So he comes in and has the surgery, has the partial nephrectomy. Unfortunately, the OR course is complicated by significant blood loss and subsequent hypotension. And so this is actually pre-op. This was the pre-op blood work that he had prior to coming for the surgery. So this is actually the labs after surgery. So he had his surgery, I guess, middle of the day or earlier in the morning on August 24th. And so actually the BUN has gone down from 59 to 44, and the creatinine's gone down from 3.33 to 2.49. So what's going on here? So clearly, I think this kind of situation may be more common in the in the surgical ICU, but I'm sure if you had someone in the MICU who was maybe hemorrhaging or losing a lot of volume. So basically, the guy lost a lot of blood, so he required blood products, crystalloids, for volume resuscitation. Basically, the creatinine in his blood got diluted, so that's why the creatinine looks better. I'm sure. Well, the question is what's happening to his kidney functions. You can't. So in this situation, you can't use the creatinine to assess kidney function. So in this kind of case, I would look at the urine output. This guy actually didn't have AKI, but I've seen there are lots of other cases where someone's in hemorrhagic shock, so they're getting a lot of blood products, fluids, and their creatinine goes down, but they're not making any urine at all. And so clearly they have acute kidney injury. And then, but the potassium went from 4.7 to 5.4. Why is that? So that's basically from multiple transfusions, right? So obviously blood, lots of red blood cells, and so the longer blood is stored, the more cells you're gonna, more cell lysis, cell senescence, more cell lysis you're gonna have. So it's not uncommon, for patients to develop especially those with pre-existing kidney disease, to develop either develop hyperkalemia or at least have an increase in potassium after after transfusion. Especially, I think this patient got multiple units. Okay, so I just want to make the point, that you have to remember that the relationship between creatinine and GFR is not linear, right? So it looks the curve that looks like this. So let's talk about some specific examples. So if you look at the yellow lines, so let's say the patient has a creatinine of 1 milligram per deciliter and it goes to 2 milligrams per deciliter. How much of a change in their kidney function does it indicate? So basically, you see that the GFR is going from 120 to 60. So it's being cut in half by the creatinine going from 1 to 2. But let's go elsewhere on the curve. Let's say you have another patient, the creatinine goes from 4 milligrams per deciliter to 5. So in that case, I don't know if it's truly 8, but just by eyeballing the graph, obviously the change in estimated GFR is it's definitely not 60. It's maybe somewhere on the order of 8 to 10. So that's why when someone's creatinine goes from 6 to 7 or 7 to 8, it really usually reflects little to no change in the kidney function. That could just be within the realm of lab error. So we're not going to get too excited about that. But obviously creatinine going from 1 to 2 is a big deal. Right. So keep that in mind. Okay, so let's move on to the causes of AKI. So I found this very cute cartoon, which basically covers it all. So you have the normal kidney giving a thumbs up, and then you have the pre-renal, the very thirsty kidney, due to decreased blood flow to the kidneys, from hemorrhage, hypovolemia, heart failure that you guys are familiar with. And then you have the intrinsic AKI, the kidney that's not feeling great. And then the post-renal, you have the urinary outflow obstruction. So I think I think this is actually a very educational, very helpful cartoon. So we could almost move right to the evaluation, but we're gonna talk about this a little bit more detail. So of course, I'm sure you guys are already have come across this multiple times. So first we'll talk about pre-renal states. So I think the main cause of pre-renal kidney injury is hypovolemia, right? So you have increased fluid losses from hemorrhage, burns, vomiting, diarrhea, or poor oral intake, or reduced cardiac output, heart failure, tamponade, massive PE. So these images are from New England Images in Clinical Medicine from maybe 10 years ago. But I thought this was impressive skin tenting. I've never seen something that's so impressive. But I think this is a patient who had, did I put that? Oh, here. So the patient had a neuroendocrine tumor, and so basically had diarrheal losses exceeding 10 liters per day. So it's not surprising that the skin looks like this. They didn't include any labs, so I don't know what I don't know what his BUN was, but I would guess that it would be quite high. Okay. Oh, also, you have, medication, anything that affects, the renal blood flow, medications, NSAIDs, ACEs and ARBs, cyclosporin, iodinated contrast. So I put an asterisk there because there's, it's pretty controversial, as to whether, contrast actually causes, acute kidney injury. I don't, I didn't include any details because I don't think we have the time, but that can be a lecture in and of itself. But my take is that we don't have to worry too much about contrast. So but I'm happy to do another lecture where we talk about that, where we talk about the evidence. Hypercalcemia, hepatorenal syndrome. I've only been here on service since May, but I've noticed that there are a lot of patients with liver disease here, and so of course the hepatorenal syndrome is always a concern. And of course, you guys see, lots of, patients with sepsis, SIRS, systemic vasodilation. Oh, so this is, these are images from a patient who had hepatorenal syndrome. So on the left is an angiogram, a renal angiogram when the patient was alive. And so you can see that you can't see, you can see the main vessels, but there's very little perfusion to most of the kidneys. And that's due to intense vasoconstriction that occurs in hepatorenal syndrome. And then the image on the right, unfortunately, is an autopsy. So the patient, unfortunately, passed away, and then they, did another angiogram post-mortem, and you can see that, the vessel is, it was that you couldn't see the vessels previously because of vasoconstriction. There's no, intrinsic problem with the blood vessels themselves. Okay. So we've talked about pre-renal. We'll move on to intrarenal. So this can be caused, by vascular conditions like renal artery stenosis, arteriovenous cross clamping, and then you have all the microvascular conditions like TMAs, with all the causes that are listed there, and then cholesterol emboli. So this is an image of obviously a biopsy of a patient who had AKI, and you can see that the clear spaces are clefts, and that's where the cholesterol crystals are. And then you have surrounding macrophages and lymphocytes. These cholesterol incites inflammatory reaction, and you have cells moving into the area. Okay, and then glomeruli, I think you guys are going to have lectures about this. So but obviously these are the coolest, right? These are always the things that that you guys that we're looking for, or that we don't want to miss. So you have the rapidly progressive GNs like anti-GBM. I mean, any of these other ones like IgA, they can also be crescentic also, but I think anti-GBM is the one when we think of. I have yet to see a case of it, so I've never seen a positive anti-GBM antibody, but I'm sure it will happen at some point in my career. Then you have the immune complex diseases, post-immune GNs, and of course nephrotic range proteinuria, and you may have AKI right in the setting of nephrotic range proteinuria due to hypoalbuminemia and third spacing. Membranous, and then multiple myeloma, and so multiple myeloma most commonly causes cast nephropathy, but you can have, there are amyloidosis, immunoglobulin deposition disease can also be seen as well. And then the tubular, so acute tubular necrosis, of course, that's the most common, as I'll talk about, so the most common etiology of AKI in the patients we see. It's most common due to ischemia, inflammation, and medications as well. Acute interstitial nephritis, which is hard to rule out. Typically all my consult notes will say can't rule out acute interstitial nephritis because it's true. And then pigment nephropathy. I'm sure we have cases of rhabdomyolysis and hemolysis as well. And then I think we don't see these crystal nephropathy, very, very frequently, but sometimes when you do have a case, you can get some very nice pictures of crystals in the urine. And then multiple myeloma, as I mentioned, causes cast nephropathy. That's the most common cause of acute kidney injury seen in the setting of multiple myeloma. Okay, post-renal, so obstructive AKI. So obstruction can occur at different levels. You can have obstruction in the renal pelvis from papillary necrosis and setting of NSAIDs. You can have kidney stones. you can have, ureteral obstruction. So if someone has 2 kidneys and their kidney function is pretty good, if you have obstruction of one ureter, shouldn't cause, it shouldn't cause a major AKI. So typically, to have, to see AKI from, from ureteral obstruction is typically, someone with retroperitoneal fibrosis or metastatic disease, lymphadenopathy or, METs in the abdomen that would affect both ureters. Or of course, there are people out there who with only 1 kidney, so obviously those people, they get, that 1 ureter obstructed, and they're going to be in big trouble. As mentioned, retroperitoneal fibrosis, malignancy, and of course stones. And then of course, bladder outlet, that's, probably the most common, from BPH in men, cancer, strictures, clots, if someone's having, significant, gross hematuria and they're forming clots. So this is an ultrasound. So this is normal, and that's, clearly, abnormal. So you can see that the pelvis and the calyces are, are very, very dilated. Okay, so this is just, we're not going to go over this, but this is a list of nephrotoxic agents that can cause, kidney injury. So this just shows that there are, a boatload of medications and other substances that can cause acute kidney injury, and they can occur, the mechanism, can vary. This is, I don't know actually when this this book was published, but, I'm sure there are more, agents that are not on this list. It seems like, there are more, there's a new immunotherapy for, for some cancer indication coming out, every, frequently, every few months, and, many of those cause AIN or other kidney injury. Okay, so, right, so what's the distribution of causes of AKI in the patients we see? So, ATN or ATI, acute tubular necrosis or acute tubular injury, that's going to be the most common. So this is from a study done in Spain, I think, before 2000. But basically, they looked at, all these other patients that were admitted to hospital with acute kidney injury, and then sort of, categorized them. So, so the most common was, acute tubular necrosis, I think accounting for about 45% of the total cases. And then next was pre-renal. So I don't really know what the blue slice says, acute on chronic renal failure. I read the paper and I still don't know exactly what they meant. But the point of the slide is that, that ATN and pre-renal are the 2 most common causes, etiologies of AKI. And then in the ICU, studies show that ATN is responsible for, 50% or more. So it's even, a higher rate of ATN in, patients who are in the ICU, which again is not surprising. I'm sure because of, sepsis, hypotension. Okay, so quickly just about ATN. So it's kind of a misnomer. So on biopsies, you don't always see a bunch of necrosis. So some, I think in my notes, I might refer to it as acute tubular injury. I'm talking about, the same thing. So why is this, why are tubules, why do they get injured so, so easily? So they're at high risk of injury because of their high metabolism, right? So they consume a lot of oxygen, and so anytime there's a fall in oxygen concentration, from hypoperfusion, from hypoxia, so they're going to get injured. And so, you have a progressive fall in oxygen levels from the cortex to medulla. So not all, tubules are, exposed to the same environment. So it's the tubules that are located in the medulla that are at the highest risk. So those are the ones that are going to get injured first in any sort of high risk situation. So, and then when you have ATN or ATI, you're going to have a decrease in GFR because, well, cells are dying. And then the cells, the actin cytoskeleton can get disturbed, so cells can literally, detach, from the matrix, and then they get incorporated into cast, and then the cast can cause obstruction, which, obviously going to impair kidney function. And then you can just have generalized, loss of, adhesion, the typical adhesion molecules that keep, everything together, and you can have a back leak of filtrate, going back into the interstitium. So this is normal tubules. They look, pretty, fluffy and healthy. And then this is, ATN. So you can see that the tubule cells are, are very flattened. The lumen, are enlarged. Okay, so let's talk about the evaluation of AKI. So, the most important things, are, chart review and history and physical exam. And maybe I can convince you that, you guys, I know you guys take good histories because I read your notes. I read your ICU admissions, and I'm reading your notes, so I know you guys, are do so. With just reviewing the chart and getting a history exam, 90, I don't know, I'm just making it up, but vast majority of the time, we should be able to, have a pretty good idea what the cause of AKI is. So when I look at, so anytime we get a consult, right, we're going to look at the chart first. I mean, I'm going to be looking at things like, what's the trajectory of creatinine? How is the creatinine changing? I'm going to be looking at the BUN creatinine ratio, not necessarily, I'm not going to actually calculate a ratio. I'm just sort of going to look, sort of, eyeball it, how is, if you look at how the creatinine is changing, how's the BUN, changing relative to the creatinine? And of course, a urinalysis. I'm always looking for a urinalysis. And then, of course, history and physical exam. And then after that, we may, think about getting urine electrolytes and phenylketonuria, doing a urine microscopy, and then, getting imaging of the kidneys, and then potentially, a kidney biopsy in select situations. So I'm looking at the chart, so like I said, I'm going to be looking at the trajectory of creatinine. How is the creatinine changing, right? So this, I think I have the history, this person's history on a subsequent slide, but this is just, I was just looking through the consult list, and came across this patient that that is being followed by the acute service. So you can see that the, creatinine was normal, and then it took a little bit of increase from 0.9 to 1.2, and then we were sort of off to the races, right? Where it's by the 21st, 22nd, the creatinine's going up by more than 1 or more 1 milligram per deciliter or more every day. So this kind of pattern where you have this creatinine going from 1, 2, 3, 4, 2, 4, 6. So I won't say it's only 8. It's always ATN, because it's never, medicine, nothing is ever always one thing. But so this is almost always, ATN. So I think the term, rapidly progressive GN, I think is a little bit misleading, because I think, because it's, rapidly progressive, people think that, oh, this, that this kind of pattern is consistent with a rapidly progressive GN. It's actually not. So rapidly progressive means, significant decline in kidney function over, days to weeks, or even months. So it's actually a much slower increase. So this kind of, basically where the creatinine's marching up progressively by, 1 or more, that's almost certainly ATN. It's not always just ATN. That's that's the problem. So I think we learn in in medical school, the textbooks try to categorize people in pre-renal, in buckets, right? Pre-renal, AKI. But patients don't read the textbooks. They not everyone follows the rules, but also it's possible for to have 2 pathologies, pathology processes to be present at the same time, which is a lesson that so I when I was at my previous institution, I saw a patient with creatinine going like this, rising like this, and the fellow said, oh, there's lots of granular cast. I said, okay, ATN, case closed, move on. But then after I left the service and the next attending came on, they ended up biopsying the patient, and it's never fun when someone says, okay, well, guess what, you missed a TMA. So the patient had ATN, but also a TMA. So now TMAs on every consult, pretty much every consult, I write, TMAs on the differential because of that one case. Okay, so sorry, a little bit sidetracked. So going back to the chart view. So next is I also look at the BUN creatinine ratio. Again, not actually looking, calculating a ratio, but just sort of eyeballing, how, how abnormal is the BUN, compared to the creatinine. So this is a patient we saw, I think maybe in August. So a 53-year-old man with cirrhosis from alcohol use. So apparently he'd been admitted to an outside hospital, with, significant, tons of, edema. And so he was, started on diuretics. And so his diuretic regimen included Lasix, 80 BID, spironolactone, 50 milligrams BID, and then he had been fairly recently started on metolazone 5 Monday, Wednesday, Friday. So I don't know, I mean, hopefully not many of your patients are on metolazone, but it's a pretty powerful medication. So that's, to put someone on standing metolazone 5 Monday, that's a lot. So so what's the differential diagnosis? Well, of course he has liver disease, and so a hepatorenal, of course, is always is on the differential. But look at the labs. So the creatinine went from 1.5 to 3.2, which doesn't rule out anything. It could be hepatorenal, it could be sepsis, hypovolemia, anything. But look what happened to the BUN. So it went from 44 to 147. So I'm sure we get patients who have high BUNs, but you also have lots of patients who have AKI and their creatinine, maybe the creatinine's 5, 6, 7, but their BUN's not 147. So I think so in this case, and then sometimes the other labs are helpful as well. So sodium is low, which although in liver disease, it may not be helpful, but the potassium is 3. So despite the fact that his kidney function has gone down significantly, he's hypokalemic. So to me, this this was all very convincing for just too much overdiuresis. And truly, he had no edema on exam, and he was hypotensive, and I think he had nearly passed out because he was orthostatic. Okay. So then the next thing is urinalysis. So of all the urine tests that are out there, I mean, urinalysis to me is the most important one to get up front because that sort of helps solidify the diagnosis, or basically helps confirm that someone has ATN or pre-renal or something, or a condition where the management is supportive care versus something else like a like a vasculitis or something where patients might need a biopsy because there may be specific treatments that are available. So the one on the left is this, the guy with cirrhosis who's on tons of diuretics. So you can see it's pretty benign, and yeah, he has no protein, he has no cells. I think, and I guess maybe he didn't have any hyaline cast. I might have cut that off a little. But then the one in the middle, so the middle guy is the one with the with the creatinine chart. With the rising creatinine that I showed a couple slides ago. So he's a 60-year-old man with respiratory failure, heart failure, hypotension. So the middle UA, that was a UA that's I think that was done I think when the creatinine started to go up a little bit, maybe 1.2, 1.6, and you can see that there's a little bit of blood, but presumably he has a Foley catheter. There's a little bit of protein. Some white cells, and then you can see that that there are 84 hyaline casts. So that's so basically he's pre-renal, which again is not surprising. He's hypotensive, hypoxic, and then a couple days later he had another UA. So by this time I think he's essentially anuric. So it does the urinalysis looks grossly abnormal. The specific gravity is high, because basically it's just a very super concentrated. He's not making much urine, so it's not very helpful, but this is just, I think it's an informative example. And you can see, the hyaline casts have been replaced with granular casts. Okay, and then, so these are, they're pre-renal, ATN, the management's going to be supportive care. But then you have a UA like this. So this is a 32-year-old man with lupus nephritis who, he presented to the ED here. Well, he was treated outside hospital, presented to the ED earlier this week, and then he says he doesn't have a nephrologist, which I don't know what happened, but he's told to follow up with a nephrologist. So he gets put on my schedule for a month from now, and but I get a note from the staff saying, oh, he'd like an earlier appointment. So I'm looking at his labs, and his albumin is 2, and his kidney function is okay, but his albumin is 2, and there's all the ED notes talk about lower extremity edema, scrotal edema, and this is his, then this is his urinalysis. So he has blood, and over 50, obviously he's an outpatient, so presumably he doesn't have a Foley catheter. He has, tons of protein, and he has lots of reds, and also hyaline casts, again, probably because he's hypoalbuminemic. It didn't look like he was on diuretics. Anyway, so I'm going to see this guy on Tuesday. Hopefully he makes it. By then, he may, I don't know, potentially he might end up in the hospital, present back with worsening edema and be admitted, or I might see him on Tuesday and take one look at him, or and send him to the hospital. So you guys may meet him. Okay. In terms of the history, of course, you're asking for things like nausea, volume depletion, use of nephrotoxins like NSAIDs. Sometimes you all know that the story. You can ask the questions, but you can't. You're not. Patients lie. You may not. The answers may not always be reliable. So, for example, I've seen a patient with a creatinine of 6 who's has baseline normal kidney function. Yeah, I haven't been feeling well. I have been having nausea. Since when? Yesterday, which does not make sense. So if someone's has significant if someone's, kidneys completely stopped working and their creatinine was 1, what would you expect it to be the next day? You would expect it to go, from 1 to 2 or 1 to 2.5. So typically, with severe kidney dysfunction, severely decreased clearance, you're gonna, the creatinine's gonna go up 1 to maybe 1.5 a day. So this guy's creatinine, creatinine clearly didn't go from 1 to 6 in one day. So clearly their illness started earlier. But then on the flip side, I have seen a patient. This is a true story. I saw a patient who he came because he hadn't urinated in 12 days. And so, but he otherwise felt well. He had no symptoms. And so he did. So he waited 12 days to show up to the emergency room, and his creatinine was 14, which actually makes, it's very possible that he hadn't, urinated for 12 days with the creatinine of 14. As for by some miracle, his potassium was actually fine-ish, so he didn't, he made it to present to the hospital after 12 days of essential anuria. And on the physical exam, you're looking mainly at the volume status, but there may be other things, especially skin findings, that may, suggest other etiologies. So urine chemistry. So I think urine sodium, I think, is helpful. It's, low in the setting of hypovolemia or reduced effective circulatory volume, but it can be misleading. So of course, diuretics. If someone's on diuretics, urine sodium is going to be high, unless the diuretic use is remote, or if the urine is very dilute or very concentrated, it can be misleading. So and so we often get a FENA. I see you guys ordering FENAs. I mean, it may be helpful, but I think I want to remind you guys that the studies where it's been evaluated, they typically looked at patients, who are oliguric and have significant, reduced GFR. So in patients who are not oliguric, the sensitivity and specificity may not be particularly high. And so, and of course, there are always situations where, you can have a FENA of less than 1%, like in ATN or acute GN. So I'm not going to, I would like before you consult us, a urinalysis would be great. I'm not going to be upset if there's no FENA or FeUrea. So FeUrea, of course, we like to use in patients who are on diuretics. So when someone's volume depleted, the reabsorption of water and urea in the proximal tubule is high, right? So the diuretics we use, act more distal, to the proximal tubule. So diuretics, loops, thiazide diuretics don't affect, urea reabsorption. So when the FeUrea is less than 35, it suggests, low effective volume or hypovolemia. But then, of course, there are always things that can affect FeUrea level, like acetazolamide, mannitol, or glycosuria. Urine sodium, I think, if it's there, it's helpful. If it's low, I think volume depletion, reduced effective circulating volume. But of course, there are always exceptions to the rule. And so there are, so there's an article from 2015 where, two physicians, one of them who's a nephrologist at Johns Hopkins, who's one of the smartest, the most brilliant people on this planet, Dr. John Sperati. And so they wrote a piece saying that these are ordered FeUreas, FeNAs, FeUreas are ordered, very frequently, but, are they really that helpful? So I think, I would, I guess going back to, emphasizing, history and physical and the chart review. So I think they're not, I agree. I mean, they tried it, well, there's some problems, there are always exceptions to the rule. Patients don't read the textbook. And I think it tends to, try to put people in buckets. But both ATN and prerenal conditions can both exist at the same time. It doesn't really help. A lot of times you want to know if the patient's hypovolemic, but these urine studies don't necessarily help different volume stats, right? Because the person may be hypovolemic, or maybe they could have a high FeUrea because they're third spacing. So the question is, does it, anytime before you order any test, think about what, how is it going to change your management? Or, are the results, depending on the results, is it going to change what you do? Most likely not. So I think, the authors argue, suggest, urine sodium or FeNA if you're concerned about hepatorenal syndrome, right? Because that can be helpful. But otherwise, think about, is it really going to affect what you do? I'm guessing in most cases, but you can order it and then sort of think about it. You have the result, and think about, ask yourself, does it change my differential, or does it change what I think the patient has? I would bet probably not in most cases. Okay. Speaking of urine, of course, urine microscopy, which, so a hyaline cast, granular cast, just more RBCs, white cell cast, red cell cast, so those are the things that are probably most relevant. So what are they? So they form in the lumen of the distal tubules collecting ducts. The matrix is made of TAM horsefall glycoprotein, or uromodulin, which is secreted by the cells in the thick ascending loop, limb of the loop of Henle. And then anything that happens to be in the lumen, can be captured, can be trapped in a cast. And so so this example, hyaline casts, they occur. It's not unusual to see a couple hyaline casts in normal urine, but when you have a bunch of them, suggests pre-renal. So granular casts, I think you guys are aware, occur in ATN. Red cell casts, occur in GNs. But you don't always see, you're lucky. It's not like someone has lupus nephritis, there's or ankylosing, there's tons of RBC casts. You might see sometimes even in patients who have biopsy proven vasculitis or a GN, you may not see them. So, and then white cell casts, they occur in pyelo and AIN. Okay, and then of course yeah, there's bazillion things that can cause AKI, so there are going to be different labs, other tests that may point you into one direction. But I think in the interest of time, you guys can review that later. Imaging. So imaging is another thing. Okay, so all my CKD patients, or anyone with GFR less than 60, I get some imaging, right? Because I want to know, what the chronicity. I'm looking for stones. I'm looking for vascular disease. But in AKI, do you need to get an ultrasound? So this is a study, 800 ultrasounds done for AKI at a hospital. 62% were normal. The most common abnormality was, medical, increased echogenicity, because this is a medical renal disease. I'm sure you guys have seen that numerous times on reports. Only 5% showed hydronephrosis. Well, 5%, it's actually not 0 or not 1%, but just because the ultrasound shows hydro doesn't mean that's the cause, right? Obstruction is the cause of the AKI, because there are patients who, chronically have, some mild hydronephrosis, or so. Only in 2.3% was obstruction thought to be the cause of AKI. But even among all these 19 patients, 14, just by getting a history, that would have been, obstruction would have been high on the differential based on the history. And then 5 of the 19 had, patients had obstruction without a suggestive history, meaning that the ultrasound was helpful in diagnosing the cause of AKI in these patients. So it's a very small, so of the 810 ultrasounds, 5, in 5 patients was ultrasound helpful in determining the etiology. So, people, generally suggest, more selective use of ultrasound. I mean, I agree. If you have someone in the ICU and they're septic on pressors, I mean, probably, obstruction is not, you're not going to find obstruction imaging. And some, patients have, may have had a CT, within the last, 48 hours, or, if they've had some sort of kidney imaging, like a CT, you don't need to get a renal ultrasound unless, unless the history is suggestive. And then the kidney biopsy, of course, when we're really interested in making a specific diagnosis, and it's going to affect, what we do, because there are treatment options for, certain things on your differential. So typically, proteinuria that's the main reason that that we're getting biopsies. AKI, I mean, typically, right, like I've said numerous times, ATN, pre-renal are the most common, causes of AKI. Those situations, you shouldn't need a biopsy unless, you're worried about something like maybe, like the AKI, ATN with TMA, like the patient I had that I misdiagnosed. And then, bleeding, etc. So in the interest of time, I'm just going to go through them quickly. So I'm not sure if any guys have seen a kidney biopsy, but so on the left, so so radiology. So I'm used to doing my own kidney biopsies using ultrasound, but here they're done by the radiologist. Radiologists may use CT for guidance, or they may use ultrasound. So the image on the left is from from a CT guided kidney biopsy, and so the the dark white line, that's the needle, or that's the trocar. And so, so yes, the patient's literally in the scanner, and with a trocar in the back. And then the middle is, this is actually, I guess, the nephrologist, whoever's doing it, they have to hold the ultrasound and do the biopsy. I'm used to having someone else, ultrasound tech hold do the ultrasound part, and me do the needle part. But you can see, so you can see on the right hand side that what the needle looks like as it goes through the tissue, and you can see, most of the times you can see the kidney pretty well, so you know exactly where you are. Sometimes it's a little bit difficult because of body habitus or other considerations. Oh, and then you get cores like this. So we use 18 gauge, I think it's 18 gauge. Well, when I was doing biopsies myself, it was 18 gauge needles, and then so you get these very, so you guys know what 18 gauge IVs look like. So it's that diameter, maybe up to an inch or a little bit longer in cores. Typically, I used to get 2 cores, send them to pathology. Here we ask the radiologist to get IR to get 3 cores, and then they get sent to pathology. And then, so on light microscopy, the middle, or the one on the left, that's a healthy looking glomerulus. You can see that the one on the right is clearly abnormal. You can actually see a crescent. So actually the dark red is the mesangial cells and the glomerula, and the lighter pink crescent is actually probably fibroblasts. Immunofluorescence we're looking for. So the one on the left, that's an anti-GBM. So you have linear IgG, and then this middle is immune complex, where you have granular staining, and then posse-immune. There's no immune complexes, of course. Nothing's showing up. Okay. So quickly, can I have 5 minutes to talk about management real quick?
Yeah,
I think it's pretty straightforward. So number one is, volume status. Given that, volume depletion is very common, most of the time, unless, someone's clear heart failure, or, liver disease and they're anasarchic, most people are going to be getting some fluids, because even people with ATN, maybe they have ATN because they have, they were volume depleted and they were, had prolonged pre-renal state. Of course, we're always recommending, in our notes, we're always recommending stopping nephrotoxic agents. But I think the one I want to, sort of talk about is making sure that you go through the rest of the medication list and and think about medications that you have to adjust, given a change in the patient's kidney function. So this is, I think, a pretty good list. So, for example, gabapentin. I'm in clinic. I'm always making, adjustments to gabapentin in my patients as the, kidney function goes down. And then any antimicrobial, antiviral, antifungals, antibiotics, almost like it says in the middle there, almost all antimicrobial need dose adjustment in AKI, which is annoying. I hear you. And then things like metformin, of course, stopping metformin, adjusting sulfonylureas, and then baclofen, lithium, etc. So. Okay, so of course we want to avoid the direct effects of having AKI, like hyperkalemia or volume, but these are sort of like some other downstream effects, like not forgetting to adjust dose reduce medications, and then having toxicity related to those agents. Okay, so dialysis. So I want to end by talking about dialysis. So I don't know if you guys ever wonder, why isn't nephrology starting recommending dialysis yet for this patient? I know the surgeons do, because I think their mentality is, okay, if there's a problem, we fix it. And so, right, labs are normal, we start dialysis, we fix it. But I'll show you why we do things the way we do. So, real quickly to review that, this slide is courtesy, I borrowed from from BG Thomas. And so I think you guys know the AEIOU indications for dialysis. And there's a nice, I stumbled a mnemonic is not one I've heard of, but that's from BG. And then so BG was giving a talk to renal fellows, in July, I think as part of NKF or one of these things. And so his indications was AEIOUF, and F is for Friday, because of course, it may be more difficult. Of course, there's less, fewer residents, fewer staff, or fewer resources, on the weekend. So maybe it's more difficult to get a line. So, so think about on Friday. Think about what the trajectory of the kidney function is. How likely is it they're getting dialysis? So you maybe pull the trigger a little bit earlier on Friday than Monday through Thursday. Okay, so why does it seem like that nephrology never wants to do dialysis? Well, it's because starting dialysis earlier doesn't help. So there have been actually several studies, but this is the most recent one that came out, I think, in July. And so this is called START AKI. And so, this is a visual abstract. So it's a multinational open label randomized controlled trial in 15 countries. And so basically took critically ill patients with, severe AKI, and then randomize them to standard of care or an accelerated strategy where they start kidney replacement. We're trying to get rid of the renal, so that's why it's KRT, not RRT, kidney replacement therapy, within 12 hours of meeting eligibility criteria. So basically, there was no difference in mortality at 90 days. There was actually a higher rate of dependence on dialysis among those who survived, and then adverse events were more common in the folks who started dialysis earlier. So this is the curve showing the survival. You can see that there's no difference. The curves are overlapping. And then so death was the primary outcome. There are several other secondary outcomes, but one of them was who's still on dialysis. Among the people who make it, who survive the hospital at 90 days, what percentage are still on dialysis? And so that you can see in the accelerated, so starting dialysis earlier, 10% of those patients were still requiring dialysis at 90 days, and first compared to 6 for those, standard therapy strategy, which means, really wait to start dialysis until there's an urgent indication. And you can see that, that there's a difference in relative risk. Okay, so any of you guys who are on Twitter, you probably are aware of Dr. Joel Toff, who's probably, I think, I'm also a Twitter newbie, but I think he's probably the most famous, nephrologist on Twitter. So after this paper came out, so he tweeted, okay, new algorithm for when to start dialysis in AKI. You ask yourself, will the patient be dead tomorrow if he or she doesn't get dialysis? If the answer is yes, then start dialysis today. If the answer is no, don't start dialysis and ask again tomorrow. So I think that's a pretty good, that's sort of how I've always made the decisions, because you really want to have a good reason, right? Because while things like line placements are pretty straightforward, you guys are very experienced, but imagine if you had a complication from a line placement. I sort of imagine as as a trainee, I wasn't too sort of worried about getting sued or whatever, but as an attending, it's I sort of if I'm not sure what to do, I think about, well, what could happen in either scenario, and is there any scenario in which I might be sitting in a courtroom being asked, well, Dr. Greenberg, why did you decide to to start that dialysis or place that line if there wasn't an urgent indication for dialysis? And then of course you guys, obviously we don't have enough time to talk about specifics. I'm happy to, and I think there's going to be a lecture about glomerular diseases. I'm happy to talk to you guys about anything else that's not already scheduled. So the key points. So you guys are already know, most AKIs ATN are pre-renal, but it's tricky, right? Patients are more complicated than the examples you get in medical school or the textbooks, right? So more than one cause of AKI may be present. So I go back. So the history and physical and sort of chart review or obtaining the history, that's the most important, right? That's where you're going to get most of the information, and that's really going to be enough in most cases, for you guys to determine why the patient has AKI. So the urinalysis is important just because we want to evaluate for things like like hematuria or skin proteinuria, where that warrant further workup that would suggest it's not just ATN or it's not just pre-renal. The fractional excretion of sodium and urea, I'm not going to be mad at you if you don't have those things. And then again, kidney imaging is helpful. I mean, it can be helpful to know if someone comes in with a creatinine 4, is it acute, chronic, to distinguish. But unlikely to provide the answer that you're looking for. Oh, it's obstruction. And then dialysis only when there's a strong indication.